Good afternoon, everyone. Today we'll be covering mixed features in bipolar disorder. So, bipolar mixed states, coexistence of depressive and manic features within the same mood episodes. It's known as bipolar mixed state. Is driven by a mechanism resembling hyperarousal, represent more severe form of bipolar disorder. It denotes the concurrence of at least three symptoms from the opposite pole of illness within either a manic or hypomanic or depressive episode. Kraepelin classified mixed states either transitional between depression and mania or autonomic. Six combinations of depressive and manic elements, that is depression with flight of ideas, excited depression, depressive anxious mania, unproductive mania with poverty of thought, inhibited mania, and manic stupor. Mixed state symptoms include identity impairment of identifying roles, family life, quality of life in mixed states, identity impairment of identifying roles, family life distant to or impact on children and patient role, love life, caregivers, patient roles, distorted emotions, breakups, social life, avoidance behavior, fear of stigma and isolation, medication side effects and comorbidity like sedation, anxiety, social phobia, physical well-being, work, identity, self-esteem, status, being a part of society. So manic and mixed manic episodes, as per Harvey, Hamdi, SADS, MRS are measures of mixed episodes. Mixed manic episodes include greater mood lability and irritability and decreased grandiosity, euphoria, pressured speech, need for sleep compared with non-mixed episodes. And depressive and mixed depressive episode, SCID 1 scale is used. Mania related factors such as irritability, increased mood, motor overactivity. Depressive manic symptoms shown to be associated with mixed manic episodes include dysphoric mood, anxiety, excessive guilt, and suicidality. Symptoms, regardless of polarity, include greater anxiety was found to be predicted by at least two depressive symptoms in mania. Worry, negative self-evaluation, increased energy, visible hyperactivity, racing thoughts as associated with mixed states, regardless of polarity. Susceptibility to mixed states and course of illness, recurrence depending on the age of onset, lifetime number and frequency of episodes, and stability of mixed states. Complications and co-occurring illness, suicidality, predominantly manic or depressive state, or in co-occurring conditions. Co-occurring anxiety disorders are associated with a poor course of illness and substance abuse. Alcohol and substance abuse may be more prevalent, possibly contributing to increased risks for mixed features and suicidal behavior and treatment resistance. Now, coming to a case, 44-year-old old female with history of bipolar type 2 for past 20 years presented with the following features. 2-3 episodes every year that last for a couple of months. Episodes are mostly depressive in nature, dominated by hyponic symptoms. History of unexplained pain symptoms. No history of hospitalization. A patient has been falling off for last 10 years. And patient has developed personality issues and refuses psychological therapy and help. Diagnostic criteria of mixed symptoms, three or more manic or hypomanic symptoms in major depressive episodes. Bipolar disorder type 1, bipolar disorder type 2, major depressive disorder. Three or more depressive symptoms in manic or hypomanic episode, which include type 2, bipolar disorder type 2 and bipolar disorder type 1 and 2. Diagnostic features of different affective states DSM-5. Mixed hypomania, seen in bipolar disorder type 1 and type 2. Mixed mania, that is bipolar disorder type 1. Major depressive episode with mixed features, bipolar disorder type 1 or 2, or major depressive disorder. Mix of increased involvement in pleasurable activities and anhedonia. Incongruent talking, for example, depressed mood with pressure of speech. Contrasting behavior, for example, elevated mood with suicidal ideation. Severely disturbed sleep, severe disruption in appetite, and no specific duration. Etiology and pathogenesis of mixed states. Circadian dysregulation, hypothesis of mood disorder, provoked by alterations in intensity of light and follow seasonal pattern. Molecular clock, chief indicator, activator of transcription is a dimerized complex of circadian locomotor output cycle caput, clock protein, and brain and muscle ARNT like protein 1. They bind to enhancer box sequences in the promoter of many genes, including the period and cryptochrome genes. Etiology and pathogeny of mixed states, switch process, whole gamut of presentations extending over days and weeks with concomitant manic and depressive manifestations that alternate over a matter of hours is referred as ultra rapid cycling bipolar. Pharmacological triggers of switching, long-term treatment with tricyclic antidepressants, TCAs, increasing synaptic levels of norepinephrine or dopamine via reuptake inhibition, causes depletion of catecholamines, tyrosine hydroxylase, and reduces symptoms of mania while increasing depressive manifestations. So, pathogenesis is described through unifying hypothesis. A clock gene polymorphisms results in VT, dopamine and norepinephrine neurons, increased TH activity, increased mesolimbic DA transmission, decreased DAT functioning, resulting in manic episode, and mood switch with increased cholinergic tone, resulting in mixed state and rapid cycle. Other mechanisms proposed are superimposed physiological states. Mixed manic states combine the hypothalamic pituitary adrenocortical activation or depression with increased catecholamine function exceeding non-mixed mania. Rapid alteration between mood states such as ultradian cycling or extreme mood instability. Transition to and from mixed states. Such transitions do occur, although mixed states may also be stable and prolonged. Clinical correlates of DSM-5 mixed features in bipolar disorder and meta-analysis. This is by Bartoli et al. Uh, titled Clinical Correlates of DSM-5 Mixed Features in Bipolar Disorder and Meta-Analysis, published in Journal of Affective Disorder in 2020. This meta-analysis study tested the correlates of DSM-5 mixed features in bipolar disorder. 8 studies were included in meta-analysis involving 3,070 individuals. Mixed mania hypomania is characterized by depressive symptoms and presence of anxiety, rapid cycling, and suicidality. No clinical characteristics were associated with mixed features in bipolar depression. Mixed features in manic, hypomanic episodes are associated with anxiety, rapid cycling, and suicidality. Assessment of mixed states. Identification of opposite polarity symptoms must account for symptoms that could overlap between depression and mania, such as irritability, agitation, anxiety, or insomnia. Schedule for affective disorders and schizophrenia change version SAD-C. Comprehensive scales such as SAD-C and the internal state scale and the multidimensional assessment of thymic states. So in DSM-5, mixed episode diagnosis is replaced by mixed feature specifier. DSM-5 provides a mixed feature specifier to its definition of bipolar 1, bipolar 2 states, and major depressive, allowing 3 or more symptoms of the opposite pole to be present, but mandating criterion B. In ICD-10, both manic and depressive symptoms to be prominent for most of the time over the 2-week period, allows a mixed state to involve hypomanic, manic, and depressive symptoms or the rapid alterations of such a state. CANMET guidelines recommend avoiding antidepressants in bipolar patients with mixed features. Support for several atypical antipsychotic drugs, for example, olanzapine fluoxetine combination, asinapine and lurasidone for mixed features in bipolar depression, and asinapine, aripiprazole, olanzapine, ziprasidone, valproate for manic patients with mixed features. World Federation for Bipolar guidelines. These guidelines focus on bipolar 1 disorder. There have been few relevant bipolar 2 disorder studies, and recommendations should be viewed with caution. Antidepressant drugs should not be prescribed to bipolar patient experiencing mixed state, as this may worsen the clinical state and increase the risk of suicidal behavior. Olanzapine, paliperidone, and aripiprazole have the best evidence for the treatment of acute mixed manic states. There was only evidence in favor of ziprasidone, carbamazepine, lorasidone, olanzapine, and ECT for bipolar depressed mixed states. Quetiapine, lithium, and olanzapine, either as a monotherapy or combination treatment, were the best choice treatment for preventing a new mixed episode after experiencing such an episode. And valproate, olanzapine, lithium might be the best options for preventing a mixed episode after any mixed index episode. Pharmacological management for the case: two mood stabilizer, lamotrigine 200 mg, divalproex 750 mg, antidepressant desvelnafix 10 mg, bupropion 300 mg, two antipsychotic lorazepam and aripiprazole 10 mg. Now, this article by Trisha Chakrabarty et al., treatment of mixed features in bipolar 1 disorder, updated view, published in Bipolar Disorders in 2020. It highlights divalproex may also be efficacious for acute mania with mixed features. The few extant maintenance studies suggest that while divalproex and olanzapine may have long-term efficacy in those with index mixed features or the prevention of mixed features, respectively. The existing evidence suggests that clinicians consider atypical antipsychotics and divalproex for treating acute mixed presentation. In a 1997 post hoc analysis, there was a significant treatment manic type interaction such that divalproex treated patient with mixed episodes showed significantly more improvement than those treated with lithium. Divalproex similarly outperformed lithium in this measure in patients with classic euphoric mania. There is also a preliminary evidence that lithium may not be as efficacious as divalproex or olanzapine in the prevention of mixed symptoms or in the long-term treatment of those with index mixed features. Treatment of mixed state: one-third to half of sufferers may be affected with mixed state. Comorbid anxiety and substance use disorder further complicate the course of illness. Mixed presentation generally indicate a more severe illness trajectory, poor treatment outcome, and a worse outcome. Contemporary approach for treatment of mixed episodes in bipolar disorder: mood disorders including newer anticonvulsants are preferred. Atypical antipsychotics are valuable either as a monotherapy or polytherapy. ECT is effective in refractory cases, and antidepressant monotherapy is contraindicated. Atypical antipsychotic, risperidone, many symptoms more responsive. RCT evidence equal for depressive manifestations. Paliperidone effective in schizoaffective disorder. Olanzapine best evidence for DSM-5 mixed feature specifier. Quetiapine effective in all phases of bipolar disorder. Ziprasidone mixed depression, poorly responsive. Asinapine similar efficacy to olanzapine with better cost effectiveness. Aripiprazole consistently more effective for manic than depressive symptoms. Classical mood stabilizer: lithium poor evidence for efficacy in mixed episodes. Divalproex sodium efficacious in acute mixed episodes. Rapid cycling in bipolar disorder. Carbamazepine evidence equivocal with respect to mixed episodes. Lamotrigine best evidence as maintenance agent for depressive polarity. Divalproex and valproate efficacious in management of mixed episodes. Prior to starting valproate, clinicians need to review the medical history for presence of any hepatic, hematological, and bleeding problems. In young women, Last menstrual periods need to be ascertained, and if required, urine pregnancy tests need to be done to rule out pregnancy. 250 mg twice or thrice daily and titrate cover with monitoring of side effects and serum levels. Combination treatments include valproate and olanzapine. Mixed episode respond well to the combination. Lithium and olanzapine manic symptoms response better than depressive symptoms. Lithium or valproate with quetiapine, good evidence of prevention of mixed episodes. Lithium or valproate with aripiprazole efficacious against manic depressive symptoms of acute mixed episode. And ECT is effective in acute mixed episodes. In a journal of psychiatric guidelines, management of mixed episode, goal is to control the aggression, agitation, and disruptiveness of the patient at the earliest. First line agents include lithium valproate, olanzapine, haloperidol, quetiapine, aripiprazole, risperidone, paliperidone, or ziprosidone as monotherapy. Typical antipsychotics include haloperidol, trifluperazine, chlorpromazine. Manic episodes, lithium valproate or carbamazepine, and for depressive episodes, lithium lamotrigine or quetiapine. In severe cases, combination of lithium and valproate to be done. Thank you.